institution and chairs. It is really a great honor for me to present today in the Egyptian Society of Nephrology and Kidney Transplantation as an Egyptian who was born here. I had my medical school here, my master's and PhD here. So it's really a great honor. I remember the first month I was doing my fellowship in Pittsburgh, where I was doing some TA work, teaching assistant, and there was a pop quiz for the PhD students in immunology. And then my supervisor was joking with me and said, "Would you like to take the test?" And I wasn't preparing or anything, and I just looked at it and said, "Yeah, sure, let's do that." And I answered all of it correctly, so he was very impressed, and he said, "You guys have good education in Egypt," because at that point I didn't learn anything in the United States yet. So this is really up and coming topic, and we talk about it a lot in different parts of the world because it really has a great impact on outcomes and fairly unsophisticated tests that can be run easily in clinical labs and actually easy and not expensive. So I'll talk a little bit about background of the test and talk about the concepts of pharmacogenomics and how it is applied in precision transplantation medicine. And something coming new, I don't know how much is it here, but definitely in the Western world and the United States, which is direct-to-consumer pharmacogenomics testing, meaning most tests in the Western world, you need a prescription for it. You don't go to labs and do it. But actually, there are ways now you can get very inexpensive pharmacogenomic testing done for you. So just as a reminder, what is precision medicine? Precision medicine is integration of molecular research with clinical data from individual patients to develop a more accurate molecular taxonomy of diseases. So this recognizes that patients are different and that the same disease in different patients is different. And really it's based on the patient environment, the patient genetic makeup, and all of these things are taken into account in managing these patients. And that with the aim to enhance diagnosis and treatment and tailor disease management to individual characteristics of each patient. So how pharmacogenomics fit in this paradigm? Pharmacogenomics is the field that combines pharmacology, which is the science of drugs, and genomics, which is the study of genes and their functions, to understand how genes affect persons' response to drugs, develop effective and safe medications, and determine the doses tailored to the person's genetic makeup. So why this is important? Do we have a problem we're trying to solve here? And these are simple statistics from the United States. There are 2.2 million adverse drug reactions that occur in the United States annually. And there is really no reason to believe that the rate of these side effects is less in different parts of the world. It's just that they have better way of capturing these side effects. Also, we lived with the fact that medication efficacy rates vary considerably. We know that not all our patients are going to respond in the same way to the drugs, and some are going to respond more favorably than others. It's just we hope that the next patient is not going to be the patient who's going to develop serious adverse reaction. It's going to be the patient who's going to respond favorably to the drug. And this way, and also, we know that there is unpredictable serious side effects. Precision medicine is not a novel concept. We always were mindful that we probably need to adjust the drugs to kidney function. We probably need to adjust to one or more of the weight, the age, or even more sophisticated algorithm like population-based nomograms. But this is not sufficient, and this way of doing business entails some strategies. So, for example, we would need to do frequent dose monitoring and titration because we know that different patients can respond differently. So we need to monitor for that. We need to go through iterations among different medications. So we may start with the patient on tacrolimus, and we find that he's developing serious adverse effects, and we switch him to cyclosporine or switch him to a non-calcineurin inhibitor. Because was there a way to find out this before we even started the patient on treatment? And this way of doing business leads to significant burden on the patient, on the provider, on the healthcare system as a whole. And our thinking around this has evolved. So instead of starting all patients on the same drug at the same dose and hope that things are gonna work out, and we monitor very closely. And if things do not work out, if the patient starts not to have the desired drug level, we start to increase the dose. If the patient starts to develop serious adverse effects, we lower the dose. And if things completely go out of control, then we switch to another drug and we go through the same cycle. And if everything fails, we may do some genomic testing. But actually, is there a better way of doing things? A better way of doing things, probably, I hope you would agree that before we touch the patient, before we give the patient any medication, we just test them for pharmacogenomics, and we decide which drug they're going to respond to, they are unlikely to develop serious adverse effects to, and what dose to start them with. And some might argue, if we look at the dose in milligram and the blood level, and we look at large number of patients, we're going to find them in normal distribution. So this means that it's probably at random and it cannot be predicted, cannot be managed. But actually, if we look closer at this curve, it's actually a group of curves that are merged together. And this curve on the far end, you have the poor metabolizers, and then you have the intermediate metabolizers, and you have the normal metabolizers, and you have the rapid metabolizers, and you have the ultra-rapid metabolizers. So knowing this information, knowing that your patient is here, is very helpful comparing to assuming that it falls somewhere on this spectrum. So how that translates into managing transplant patients. This is a recent article. So in this article, and it is by a prestigious group, they look, and I'm not picking on them, there are many, many articles like that, I just picked one. And it shows that higher calcineurin inhibitor levels predict better kidney graft survival in patients with de novo donor-specific HLA antibodies. And they show very elegantly that patients who are on tacrolimus level more than 6.3, they have the best graft survival after development of donor-specific antibodies. And the patients with the lowest dose actually have the worst graft survival, which was statistically significant. And this is not surprising or novel. Even in the 2000, over a decade ago, it was looked when people were looking very closely at minimization, calcineurin inhibitor minimization and withdrawal. It was shown clearly that those who maintain the same level do significantly better than those with minimization, and even better than those with complete withdrawal, and that was applicable to both cyclosporine and tacrolimus. So the message from this body of literature is that more is the better, right? You get better outcome if you get better graft survival if you give more immunosuppression. But it wouldn't surprise you to know that giving more comes at a cost, because there is more dilates mellitus. This is a study in liver showing that broad tacrolimus levels more than 10 nanogram per ml correlated with impaired kidney function, and the doses more than 0.15 mg per kg per day were associated with prevention of acute cellular rejection, which is a good thing, but actually predisposed patients to infectious diseases. So how pharmacogenomics can play into this? So this is the tacrolimus. So this is the journey of the tacrolimus, where it goes from the intestinal epithelial cells, where you have this enzyme, CYP3A5. It is one of the genes that control cytochrome B45, 450, and then it goes from here to the liver, where the same gene takes another crack at it and do more metabolism, and then what ends up in the circulation, that's the effective part that affects the lymphocytes and affect the immune suppression. So just not to oversell the product, this is not the only gene that affects metabolism of tacrolimus. And even this whole process, this is what you can call genomics of pharmacokinetics. There is a whole world of once the tacrolimus starts affecting the lymphocyte, the pharmacodynamics of it, which also has some genetic elements to it that would control it. But what we know thus far is that CYP3A5 really has very good correlation with drug levels. If we go to the genetics of CYP3A5, we have the wild type, which is the STAR1 allele, which has the normal function. And we have the STAR3 allele that has loss of function, and this is common in most populations. And we have the STAR allele 6 and 7, which are also loss of function in African Americans mainly. And this study shows that in Caucasians, the majority of patients are actually low metabolizers. So we said that the one is the normal function, the high metabolizers, and the incidence of this is about 7%. And if you compare this to African American, the incidence is 60%. So basically about almost 10 times as high. So what this really means is that African American, on the average, without doing any testing, they have higher chances of having lower tacrolimus blood levels. And the classical wisdom in the Western world is that we used to think that being African American is a high risk for rejection. These patients just have these bad immune systems that just keep projecting on us. But actually, it may not be that at all. It may be that's the case that they are not getting enough immunosuppression. I'm not saying that this is all to it, but at least this could be a factor playing into it. And if you look at the Middle Eastern, they are actually somewhere in between. They are about 10%. But this is a small study. Not that many Middle Eastern have been studied. And also not all Middle Eastern are the same. People in Egypt are not particularly the same like people in Iran or people in Turkey. And that leads to, if we look here at the high metabolizers, these are the intermediate metabolizers, and these are the low metabolizers, we find that significant differences among different patients with different ethnic backgrounds. This is a study that was fascinating to me. I read this study when it first came about 3 years ago. And really there was like aha moments reading this study. One of the things is that I wasn't very familiar with the distribution of genotypes. I didn't know how many patients are high metabolizing. And I was pleasantly surprised to know that actually very small proportion of patients are high metabolizers. These are about 7% in Caucasians. I didn't even know at that time that there was significant difference in different races. And in this study, they classified patients who were low metabolizers, and they give them small doses, right? If they don't metabolize as much, then they don't need as much drug, and you can give them lower doses. And if they are high metabolizers, like the STAR1 group, then you would expect them, if you give them a little bit more, they would achieve the same blood level. But look at the results. It was really very impressive. Group 1 and 2 are the two groups that had low dose. But look at their blood level, 120 to 103, compared to those who are high metabolizers on a higher dose, that they have 38 and they have 32. And when I talk to our clinical pharmacists, they tell me that patients, and also the literature supports that, patients who are high metabolizer, it doesn't help to give them 10% more or 20% more of the dose to achieve the standard blood level. You actually may need to give them twice as much or 3 times as much. And when I talk to my colleagues who are nephrologists and ask them, without doing any testing, would you feel comfortable starting your patients on 3 times the standard dose? It's like, absolutely not, that's crazy. So then, what if I give you a test result, so that tell you that that's what is going to achieve this? He said, yeah, I would do that. If there is a test that tells me that, then I would be comfortable to do that. This is another aha moment reading this study. It looks here at the patients within the therapeutic range. And you can see that regardless of the genotype, all our patients, it's actually less than 60% of our patients are in the therapeutic window. Isn't that, kind of disappointing? Because where are the rest of the patients? The high metabolizers here are in the infratherapeutic range. So because they metabolize, they chew on the drug like there is no tomorrow, and they have this low levels. And if you look at the low metabolizers, they fall in the group of the supra-therapeutic range. So does this affect outcomes? So now it is very convincing that patients who are high metabolizers can have low drug levels, low metabolizers can have high drug levels. But we adjust for that using the monitoring blood levels. Does this affect outcome? And actually this study shows clearly, but this study is in African American, and I want you to remember this for a moment. And here you can see clearly the survival curves that patients who are high metabolizers had actually lower outcomes. And if you look at the dose that they need, however, total dose or dose per kilogram, you find that patients who are high metabolizers, two things you would notice here. Not just that they need higher dose, they are more variable and less predictable compared to the group of the low metabolizers. And as a result, the time it takes to achieve therapeutic blood level actually is longer in high metabolizers. And this is, who knows, that might be the critical period in the graft time that not having adequate immunosuppression could actually affect the long-term graft survival. I would like to mention this study because there are some studies like this that shows actually there is no effect of pharmacogenomics. And this is just a complete waste of time, and nobody should bother with this. And this is the controlled randomized trial published in AJT, American Journal of Transplantation. And again, I'm not criticizing the study, I want you to take note of some point that might not be. They compared patients in the supratherapeutic, the therapeutic, and the infratherapeutic or subtherapeutic between the standard dose, the genotype-based dosing, and that there was no significant differences between the groups. And you look here, the difference is really, there is no difference, right? So what happened is that, and they looked at the curves, there was no difference in survival curves. Anyone why this study is so different than the other one? Well, if you look here, you will find that 80% of the patients were white. And I showed you that most whites are low metabolizers, and the dose for which the standard dose was developed. So it is not surprising that it works well for them. But if you are white and high metabolizer, if you are non-white, then the chances are you may not do as well. And as I mentioned, there are many other factors. CYP3A5 is not the thing that is going to control the world. There are other factors, and here we can see that if compared to other factors that affect metabolism, such as albumin, age, weight, hemoglobin, we can see that here the p-value for CYP3A5 is -29 compared to -5, -4. So really it has significantly higher impact on tacrolimus level than any other factor. There are other drugs for which pharmacogenomics really plays a significant role that nephrologists would use, like warfarin, clopidogrel, simvastatin, and so on, and becoming also metformin for treatment of management of diabetes. One quick thing I will mention is that, and this is something I scare my colleagues in the United States, I'll tell them, if you don't test your patients for pharmacogenomics, they're going to go get it for $50, which is not a lot of money in the United States. And they're going to come to you and they tell you, I have this gene, I have CYP3A5, high metabolizer. What are you going to do about that? I told him, I don't want this to be your first time ever to hear about CYP3A5. I'd rather you know about it, test for it, and you tell the patient about it rather than the patient telling you about it. I hope this is convincing to you. I know I'm running out of time, but I want to show you one last thing, is that it seems like no-brainer, right? Especially if I tell you that the cost of the test is significantly less than HLA typing, than antibodies, than...
Dear doctor, your time is up.